Yes, I can hear you, Joseph.
Yeah, so this should be everyone's maybe practice. If you're sitting around and you don't have anything to do, you open HumanDx and you solve a case. That's how you build your medical knowledge. So this is a 32-year-old female with dizziness. That's the complaint.
Okay, 32 years old, female or male?
Female.
32 years old female with dizziness. Okay, uh, so the way I approach dizziness is that dizziness is can be it can seem like a very specific complaint, but I think the first effort that I try to make whenever I come across dizziness is to ask questions and try to be as specific as possible, because sometimes it may not be possible, but I need to make sure that I clarify whether I'm dealing with dizziness or I'm dealing with vertigo. So those are two words that are very close but different, because when you talk of vertigo, I almost leave out everything else and just focus on the vestibular system. So whether peripheral or central, I deal with balance whenever I hear about vertigo. But sometimes it can be difficult for people to clarify whether they are dealing with just dizziness or vertigo, and therefore dizziness is more broader and it can entail vertigo, but vertigo is very specific. And so one thing is, if someone sees as if the environment is spinning, or they themselves feel like they are spinning, and especially the environment around them, then to some extent I have confidence that I'm dealing with vertigo, and therefore I go down that path. But then if I'm just dealing with dizziness, dizziness is a very broad complaint, and therefore my thinking is, and I think I have a different approach, but I loved an approach that Joseph discussed one time, that whenever you are dealing with dizziness, it can imply a lot of things, but one of them is this patient is probably having issues that are leading to hypoperfusion, including in the brain, and therefore you could be dealing with an issue with the pump, which is the heart, or you are dealing with an issue with the pipes, which are the blood vessels, or the fluid itself that is circulating when someone is volume down, and therefore an approach to dizziness in some way can be very similar to an approach to shock. Just throwing some random differentials is that someone can have dizziness because they are anemic. That is because of reduced oxygen carrying capacity of the blood, and therefore the brain is not getting everything it's supposed to get. Someone can be dizzy. Someone can be dizzy after uh, terrible diarrhea or vomiting, and therefore they are volume down, or they have bled due to whether internal bleeding or trauma, and therefore because they are volume down, they have dizziness, hypoperfusion of the brain. Because the way dizziness comes, just quick physiology, which will not be very precise, but you have some receptors, baroreceptors to be specific, in the carotid body, and you also have some baroreceptors, uh, baroreceptors, if I remember correctly, even in the hypothalamus. Yes, there are baroreceptors in the hypothalamus, and therefore, so these sense the pressure of the vessels. Yeah, so volume down, anemia, I discussed those, and another one is you can have dizziness because of autonomic dysfunction. So someone who has diabetes, someone who has degenerative a degenerative neuropathy with degenerative diseases can have dizziness, and then you can have dizziness as when you have problems with the pump. So just a few examples, like if you have arrhythmias, you can present with dizziness. So I think suffices to say it's very broad, and therefore let's hear the HPI and see how far I can go.
Okay, thank you. That's a nice approach. Yeah, so let's see. This is the HPI. These symptoms have been there for some time, and the patient describes the room as spinning, and the episodes occur several times a week with interval disequilibrium. The episode lasts for 25 to 30 minutes and disappear only to come back later. She also reports left ear pressure, which has been there for some months. And the dizziness is associated with intermittent left facial spasm. She denies fever or head trauma or hearing loss. That's the short HPI.
Yeah, very interesting. So this is what physicians have to deal with, because I think to make your work easier is that you would have to refer this patient to an ENT specialist. But so everything starts with physicians and can end with physicians. So, like I said earlier, the first thing I try to do is clarify whether I'm dealing with dizziness or vertigo. And as it seems here, I'm dealing with vertigo, because this patient is experiencing a spinning sensation of the room, and there are some associated symptoms. You said ear fullness or ear pressure. I think I heard ear pressure, and
Ear pressure.
yeah, ear pressure. And another thing is that the patient is experiencing intermittent left facial spasm. Is that right?
Yes, yes.
Okay. Yeah. So I am dealing with vertigo, and because I'm dealing with vertigo, and so again I'll discuss my approach to vertigo, which is just for educational purposes at this point. And of course, I have not perfected my approach to vertigo, because I remember a number of cases that Joseph presented to me. I come close to the diagnosis, but then miss it by some inches. So I think I have not perfected it. But so when I think of vertigo, vertigo can be of central peripheral origin. And so whenever I hear some ear symptoms, I naturally become inclined or biased towards thinking about a peripheral cause of vertigo. So, for example, this patient is experiencing ear pressure, and therefore I will think about an issue, particularly in the inner ear, that is causing part of this presentation, and therefore this makes me biased towards a peripheral cause of vertigo as opposed to central. Although there is something else that I've heard here, that this patient is also experiencing intermittent left facial spasm, which I'm not sure what to make of at this point in time, but I'll believe I'll make some progress. But generally, vertigo can be of peripheral origin or central origin. And central is, for example, when someone is having a brainstem stroke, or yeah, a posterior circulation stroke. For example, when there is involvement of the cerebellum and the central connections that are involved with balance, they will present with vertigo, but which will be of central origin. And that is the most dangerous form of vertigo. So there are some tests that you'll have to do, like the HINTS exam. And particularly for this patient, I think a HINTS exam will be important, although some clues are pointing in the direction of peripheral vertigo, but we should not celebrate too soon. And therefore, I think a HINTS exam will be important, and I'll say a HINTS exam rather than a Dix-Hall-Pikes maneuver, because another cause of vertigo, intermittent vertigo, is when you have benign paroxysmal positional vertigo. So BPPV comes with very short-lived episodes of vertigo. most of the time you are talking about 30 to 45 seconds, not even minutes. And therefore, because this patient is having episodes of vertigo that are lasting minutes, 25, 30 minutes, that is not likely to be BPPV. And BPPV comes with especially changes in position. So if you hear vertigo that is more persistent, I leave out the Dix-Hall-Pikes maneuver, which is meant to confirm whether you are dealing with BPPV or not. And I think I'll do the other test because this is more long-lived than the vertigo of BPPV. Yeah, so I think the ear pressure that I'm hearing, I'm thinking now my differential when you talk of ear pressure will be limited because I'm not an ENT specialist and it's been a while since I dealt with ear problems in detail. But so ear issues that will come with vertigo is definitely not otitis externa, for example. Otitis media, again, it's not the thing. We have the outer ear, the middle ear, and the inner ear. So when you talk of vertigo, you are most likely talking about an inner ear issue, which so for example, when you have uh, what's the word again? Okay, it's not, yes, labyrinthitis. Thank you, thank you, Nebo. The help came just on time. Uh, so when you have inflammation of the labyrinth, that's the word I was looking for. So labyrinthitis. I think that will be one of the things that are high on the list for me. And yes, of course, you can have a middle ear infection, that is otitis media, which is peeling out to the inner ear, and therefore that could be a possibility, and that's why the patient is experiencing ear pressure. So other differentials like vestibular neuritis. Yeah, so I think labyrinthitis, vestibular neuritis will be one of the things that I'm considering with this patient because of the ear pressure. And then now I think the hard part that I have to deal with is this patient is experiencing intermittent, the patient is experiencing intermittent left facial spasm. So when you talk of left facial spasm, the nerves that are responsible or that are innervating the muscles of facial expression is the facial nerve. Basically, it's the facial nerve. And I do understand that the facial nerve has a long course, and part of the facial nerve is actually I think you all know the coda tympani. So the coda tympani is traversing through the ear, but there's a part of the facial nerve which is going through the, is it called the internal auditory meatus? I think that is the word, and therefore uh, it's very likely that whatever is going on is involving the labyrinth. When you are talking about the meatus, it's very close to the cause of the vestibulocochlear nerve. Yes, and that's the vestibulocochlear nerve, and therefore that's where the vestibular branch is being involved, and then that is also likely to involve the facial nerve as it causes through the internal auditory meatus, if I'm correct about that. So that's what I'm thinking about because of Venn diagramming these two, that you have a left facial spasm, and then you have ear pressure, which could be due to labyrinthitis. And I think that the facial nerve is touched as it passes through the internal auditory meatus, and that's what explaining this. And therefore, I think my confidence is a bit high about about a peripheral cause of vertigo, most likely labyrinthitis, also with involvement of the facial nerve as it causes through the internal auditory meatus. But another thing I think, because as I said, I have not perfected my approach to vertigo, I think vestibular neuritis should be patterned. I'm not sure if I'm talking of the same or different things. When you talk of labyrinthitis, so is labyrinthitis uh, is vestibular neuritis, for example, a complication of labyrinthitis, or are they separate issues? I think I'll leave that to Joseph to tell me later when it comes to the teaching points, because I think my anatomy is a bit shaky here. But that's what I'm thinking of. So I think just to be sure, I would like to hear the hints exam, which will differentiate between a peripheral versus a central cause of vertigo. So back to you, Joseph, because I think I've been talking for a while.
Yeah, nice approach. So we go to the physical exam. Um, the patient didn't have nystagmus on examination, and the hints was normal. Also, about the systemic exam, all systems examined, including a neuro exam, was normal. But so there's mentioned here special tests. Otoscope was normal. The tympanic membrane was mobile with the valsalva, which is normal. And so they did what is called a Weber test, where the 512 hertz tuning fork did lateralize to the right side. What they did with Weber test, lateralized to the right side. And also, it was observed that the patient had decreased left corneal reflex. Patient was sent to audiogram, which showed moderate sensorineural hearing loss in the left ear with a 30 to 40 dB asymmetry to the right. Other systems were normal.
Okay. So the hints exam you said was normal. So the hints exam includes a number of things. So one is the head impulse test, which you are briskly moving the patient's head while they are gazing in the primary position, and then you turn it to quickly to one side, and then you see if there are some catch-ups saccades, which so that is the head impulse test. And another one is test of skew. You so when the patient is so you are covering uh, one eye at a time. Joseph will explain this better. uh, and then so basically when you are doing test of skew, if the test of skew are positive, they are more concerning for a central cause of vertigo. And so I talked about head impulse test, and then nystagmus, which we are told the patient has no nystagmus. And so nystagmus, it can be horizontal nystagmus, or vertigo, or vertical nystagmus, or rotatory nystagmus. And so some forms of nystagmus are more concerning for a central cause rather than peripheral. So this patient has no nystagmus. Uh, we are told the hints exam is normal. And so what I remember, because again my knowledge is very limited when it comes to vertigo, is that when you have someone with vertigo and some tests in the hints exam you are told that they are normal, that is very scary, because it makes you think about a central cause of vertigo. But regardless, I think because of the earfulness that we've been told about, and of course another thing is I should also think about this, because we cannot completely rule out a central cause. Why? Because uh, so involvement, although the facial spasm that we are hearing on the left side, I feel like it's more of irritation of the facial nerve rather than a palsy, because a palsy a facial nerve palsy would be more worrying for a central cause, because the nuclei of most of these nerves, and when you talk of the facial nerve and the vestibulocochlear nerve, that is cranial nerve number 7 and 8, they have their nuclei are very close. They are very close, and therefore, I mean, the symptoms that we hear about could mean that if you are talking of something vascular, then it's also a possibility, because the nuclei are very close. So if it's big enough to involve both nuclei, that's a possibility, which will take me back to the time course. When did these symptoms start? But then we are so. What was the start? Was it the onset? Was it hyperacute, or was it acute and slowly progressive? So for this patient, the episodes of vertigo are intermittent, although they are long lasting, but intermittent, lasting some 25 to 30 minutes. And I think the patient has been sick for a number of weeks, if I remember correctly. So the vertigo of central origin, especially when it's vascular in nature, would expect it to be persistent rather than relapsing and remitting. So I think although both of them are possibilities, but the nature of the facial symptoms and also the nature of the ear symptoms, I think are more concerning for a peripheral cause rather than a central cause. And so I think that is the path I'm taking, and I'm willing to take the risk of missing the diagnosis and learning from what happened afterwards. Yeah, so those are my thoughts. But then coming to the Weber's test, so these are ENT tests. There is Weber's and there is Rhines. To be honest, I do not remember correctly what each one of them is testing. So the conclusion is that this patient is having sensorineural hearing loss. And so when someone is having, because the Weber's and Rhines, the issue is to see whether air conduction is better than bone conduction. And so one, especially if you find so one of the abnormalities will tell you that it's more of conductive hearing loss, especially when you have something like cerumen impaction, for example. So conductive hearing loss. But this patient, the conclusion is that there is sensory neural hearing loss, which means there is involvement of the vestibulocochlear nerve. So the entire nerve is involved. The vestibular part is involved. That's why we have vertigo. The cochlear part is involved. That's why we have hearing loss. So I think those are the conclusions that I'm coming with. So yeah, I think I'm still at the same point that uh, I think this is something peripheral, although there is this thing here that the Hints exam is normal, which is very worrying for a central cause. But the other symptoms, I think for me, they are more pointing in the direction of a peripheral cause. So back to you, Joseph, and I'll see if I can make more progress.
Um, I think now you have to come up with the diagnosis, because last uh, the last aliquot will give you a diagnosis.
Okay, so no tests. So apart from the exam tests that you reported, there is no
Uh-huh,
imaging, no
yeah.
nothing.
Yeah, so the labs were completely normal.
Okay, the labs are normal. Yeah, so I'll try to represent this problem and remind me how for how long were the symptoms there?
Months.
The symptoms were there for months.
Yeah.
Okay, so problem representation. This is a 32 years old female who presented with a weeks to months history of intermittent episodes of vertigo. lasting 25 to 30 minutes for each episode, and she has some free periods and then they come back. These symptoms are associated with left ear pressure and intermittent left facial spasm. We so from the history we didn't hear about any comorbidities, hypertension, diabetes whatsoever. I saw Joshua asking if this patient was any medications, and of course that's important because there are medications that can cause vertigo. So Joseph presented to me a case here of pregabalin induced vertigo, and I missed the diagnosis because this patient was an old lady presenting with some symptoms, and I think she had some comorbidities, and therefore I was very concerned about a cerebrovascular event because those symptoms were rather abrupt. So it's important to rule out medications. We are told the patient is not on any medications. So that's what we have. And then coming to physical exam, the HINTS exam is normal. Um, so, and there's mild sensorineural hearing loss. I do not remember anything else. So, before I go and discuss the diagnosis, I saw Mashauri, I think, who was asking about Dick's Hall Pikes test. Yeah, so because these episodes of vertigo are longer lasting than a few seconds, we are not thinking of BPPV, benign paroxysmal positional vertigo, and Dix-Hall-Pikes maneuver is only relevant in BPPV, so it's not relevant for other causes of vertigo. So if you come across vertigo that lasts longer uh, than seconds, then you are likely not dealing with BPPV, and therefore you rather do you do a HINTS exam rather than Dix-Hall-Pikes maneuver. Yeah, so I'll go through the chart. There can be some help here. Neb already talked about labyrinthitis, which I think is the issue here. No medications. So Michael is saying vestibular neuritis, no auditory symptoms. Labyrinthitis has auditory symptoms. So yeah, I think we're on the same page. I'm thinking more of labyrinthitis. Yeah, Meniere's disease. Yes, so there's this thing called Meniere's disease, and this is Roland. Now I've read about Meniere's disease, but I'll tell you I've forgotten everything I read about it. So I'll see if that is something that comes up in this patient, and yeah, likely because this patient has been having. But then I'm thinking, if I remember correctly, when you talk about Meniere's disease, it's a bit persistent, like the case with vestibular neuritis or labyrinthitis. But then I do not remember if it is associated with ear symptoms. So I think that is the caveat. Then Michael is thinking about stroke. So the thing about if this vertigo was of central origin, we would not expect ear symptoms, and then a posterior circulation stroke, and especially if it happens at the cerebellar area or other surrounding areas, is very dangerous because whatever the kind of stroke it is, especially for example, if we say it's hemorrhagic, for example, or even if it's ischemic and then edema happens, that's very, very lethal. And the fact that this patient has been having these symptoms for this long, so I think for me that goes against the diagnosis of stroke. And another thing is that we are not told of any comorbidities or risk factors for stroke. This patient, we are assuming, because we are not told, she's not hypertensive, not diabetic. Of course, we do not know anything about. We are told she's not on any medications. So I think those are against the diagnosis of stroke. But then we'll see. Yeah, imaging. I think imaging is important here. Um, yeah, Roland again is talking about Meniere's disease. Yeah, I think because of my limitations, I'll have to go back and read about Meniere's disease. But because this is where I'm supposed to commit, so Joseph, what I'll say is that this patient is having vertigo of peripheral origin, and the inner ear is likely involved. I'm thinking labyrinthitis. That's why this patient is having ear pressure, and the intermittent facial spasms that the patient is experiencing are because of irritation to the facial nerve as it causes through the internal auditory meatus. Those are my thoughts. So Meniere's disease, I think I know little about it to put it as part of the differential. So I'm thinking that is what I'll go with, and just sit back and learn from the case resolution and the teaching points. So back to you, Joseph.
Yeah, thank you very much, and thank you for the chat. I think you're on point. The answer comes from Michael, who needs an imaging. So this patient did an MRI of the brain, which showed a 2.2 centimeter T2 and contrast enhancing lesion at the left cerebropontine angle, and which later was uh, operated and found to be an acoustic neuroma. So that's the final diagnosis. Some few teaching points. So let me start with the questions that you asked. Is I'm also seeing the case for the first time. I didn't have time to look at it, so I'll use what I know about dizziness. And some have been answered, like the difference between labyrinthitis and vestibular neuritis. Well, yes, they both have dizziness and other symptoms, but what differentiate them is the labyrinthitis also present with hearing loss. Hints, yes, you're very right. So if you approach dizziness, we will see where hints comes from, is to know what to do at a particular time. The first thing is to know, is it an acute onset or a chronic one? And an acute onset is, I'm sitting right here, all of a sudden, dizziness and vomiting and everything, and I go to the hospital. Say this is an acute persistent dizziness. The diagnosis are just two: posterior circulation stroke and vestibular neuritis. Well, that's where you do a hint, because at that moment, a hint outperforms an MRI. It's very early, maybe 1 hour, and the MRI doesn't show anything in the posterior circulation. You do a hint, it shows you, and it shows you whether it's a peripheral or central. And David is right to say, if your hint is quiet, there is nothing, and patient is presenting like that, acute, very bad acute onset of vertigo, it's highly likely to be a posterior circulation stroke. Otherwise, don't have to perform a hint because it will be chaos. So on the other hand, now you have chronic dizziness that is there, and on that side, now you have, if I remember correctly, the forms of dizziness which are chronic, like they are there all the time, or the ones which I think they are acute, yeah, something like that. So no, that's not right. What I mean is you have the forms of dizziness which are triggered, and that which are they are not triggered, they just come. For example, think of BPPPV, that will be triggered by change in head position. But you have some forms of headache which comes and go, but they're not triggered, like maybe vestibular migraine, or what you're saying here, Meniere's, and maybe there are some. So what I forgot is the category that CNS tumors sits, and I think that's a form of long-standing chronic headaches. I mean, long-standing chronic dizziness, which are not triggered; they are just there. So if I was solving this case, the only difficult would be there. So I think I should have taken 25 minutes most of the days for months to be a chronic form of untriggered vertigo. The But maybe that will be difficult to come up with a diagnosis. But if you look at the case, David, I think the diagnosis will come if you want to localize this disease, because uh, you see that the fascial nerve and the fascial nerve and the cranial nerve number 8 and 7 are affected. You think, where can these two pass? And yes, it's a cerebral ponton angle. This has to be that. Maybe that's what the part that could come up with what's going on. Although there are no other symptoms like headache and stuff like that. So in the teaching points here, I think they say, so this patient underwent microsurgical resection via middle cranial fossa craniotomy with total tumor removal and preservation of the cranial nerve 7 and 8. She did well after surgery with no residual deficit and had full resolution of vertigo. Vestibular schwannoma is a benign neoplasm of Schwann cells of cranial nerve 8 that can cause sensorineural hearing loss. Most vestibular schwannoma present with unilateral sensorineural hearing loss, but can also present with vertigo, unilateral tinnitus, or fascial nerve weakness. New cases of dizziness should be evaluated with a full neuro and otologic exam as well as audiogram. MRI of the internal auditory canal helps differentiate between vestibular neuritis and other causes of asymmetric hearing loss, like Meniere's. Okay, so treatment include observation for older patients with small tumors, radiotherapy, or microsurgical resection. Yeah, so David, that was the case.
So, Joseph, can you read again where exactly the tumor was found?
Um, in the cerebropontine angle.
Okay.
Yeah,
Okay.
it's
Yeah.
a cerebropontine angle tumor.
Okay. Very interesting. Yeah. Of course. I think one of the things that totally uh, escaped my thinking was that is this thing called acoustic neuroma. I've read about it, but then again, I do not think I would have made that diagnosis in this patient because I saw my hindsight bias now. Things seem more predictable after you've gone through them. Looking back, acoustic neuromas, and yes, I think even if I rediscussed this case after reminding myself about acoustic neuroma, is that again the textbook picture that I have about acoustic neuroma is that it's not something that is within the brainstem, like you said, at the cerebropontine angle. But what I'm thinking of is that a tumor sits in the internal auditory canal. I think that's the textbook picture that I have about an acoustic neuroma. So, but regardless, I think this was a good learning exercise for me because again, I had to recall a few things that I know about vertigo, and then again to see the gaps that I need to go and cover. So, for example, I've come across Meniere's disease in the past, but I could not recall a sentence or two about Meniere's disease. So, a good learning exercise. I think I have some things to go and learn about. So thank you very much for the random case, and it's been a fun learning exercise.
Yeah, one thing is so it's not an acoustic neuroma, it was a vestibular schwannoma. And a vestibular schwannoma, a tumor of the Schwann cells of the vestibular nerve, and what passes in the cerebropontine angle cranial nerve 8, 7, 5, 6. That's a correction.
Yeah. So yeah, again, I'll have to go and check that. But so as I think And of course, this is some distant memory, but what I remember is that those terms, so when you talk about an acoustic neuroma and a vestibular schwannoma, as my remembering is that they are used like synonyms. They could be different things, and maybe that's where the confusion is coming about. So I'll have to go
Uh-huh.
and check
Okay.
about it. Yeah,
Okay. Yeah, I
yeah,
didn't know if they're the same.
yeah. I
Okay.
think
Thank you.
yeah, I as I remember, but then we'll have to go and check to avoid confusion.
Yeah, so that was a rescue case that is randomly selected. Is there anything else?
Yeah, so I see the chat was busy today. Thank you for the help with everyone who discussed. And so we have like 2 minutes. So if anyone would like to share some experience, share some pearls, or any questions, please welcome before we close. Yeah, I do not see any hands. So thank you very much, everyone, for joining. So Michael will let me know if next week we are going to have a case from him. So I believe Joseph will be happy to discuss that case. I'm avoiding to discuss it because I think I have some leads, although I do not know the diagnosis. But then Michael mentioned something which will make me think in a certain direction. That's why I'm avoiding to discuss the case. So whenever you are ready, Michael, you let me know so we can see if we can uh, we can hear that case next weekend. So for others who are in the chat, please bring your cases. I know you have some interesting cases, and even if you have a case which doesn't have a diagnosis yet, just bring it. We'll discuss here, and who knows, maybe the patients can benefit from the minds here and get some help. So bring your cases, and again, the discussion is not limited to me, Joseph, or Michael and Seba, or Fabian, who was discussed sometimes here. Every So the discussion is open for everyone. So we will be happy to have some new discussants. So having said that, thank you very much for joining, and have a good week ahead and a good night. See you next Sunday.
See you, Joe.